Welcome to another episode of Dr. Doctor, the award-winning radio show and podcast featuring your host, Dr. Tom McGovern.
And Dr. Andrew Mullally, where we and our guests discuss relevant and health-related topics from an authentically Catholic perspective. Dr. Doctor is brought to you in part by the generous underwriting of CMF Curo. Learn more at mycatholichealthcare.org. Live your Catholic faith in your healthcare with CMF Curo.
Today, our guest will be heard across the EWTN Global Catholic Radio Network. Joining us today will be Dr. Leah Acosta, a neurologist specializing in neurodegenerative disorders like dementia, which she is going to update us about today. Now, Andrew, we covered this about 4 years ago in our first year, our first summer of recording. Why is it important to do an update now?
Well, I'd say there's a lot of reasons. Dementia is something that I would say probably affects most people in their life in some way, either through a loved one or themselves. And it's something that I know in just talking to patients, people are constantly worried about. That's one of the most common things that we'll talk about, especially at wellness exams as folks get older. You know, I'm having memory issues. What is normal? What is abnormal? Why it's important to figure out what can we do about it. It's going to be a good episode.
I think so. I know recently my father died, and he had progressive dementia for 5 to 7 years that we noticed it. And it had a profound effect, especially when he was in a nursing home and during COVID, 8 hours away from us. It's really hard to communicate with someone with dementia who's not very verbal from a distance. Thank God for, we could video chat with him, and he could at least see us, and we could sing to him, we could pray with him, which was quite valuable. I'm sure on a daily basis, this is probably part of your practice.
You know, it is. It's not as much as some people's, I'm sure, but the times that I've run into dementia, especially in the outpatient setting, they're memorable because they bring unique challenges. And everybody's different. Their situation's different. Their support system's different. I've got a story. It's kind of a sad story related to COVID and dementia as well, where I had a patient who I really cared for. Really nice guy. He reminded me of a Pixar character. Just the funniest, little, kindest gentleman. And he was just the nicest guy. And I probably had known him for 5 or 6 years. And, he had described some memory issues early on. And he was kind of casual about doctoring anyways. And so he'd miss appointments here and there. And then over time, you could just see it was getting worse and worse. And this gentleman had no relatives, no family to speak of. And there's at least 2 or 3 times that we made way above average efforts in trying to locate or identify family members. But as things were getting worse, we reached out to Adult Protective Services and stuff to help him. And this guy had been living on his own, still driving to the office for appointments occasionally, which kind of scared all of us to death. And ultimately we're like, he last visit I saw him, he didn't remember my name. He didn't remember the meds he was taking. And he drove there. And I said, okay, this is not okay. So we were trying to figure out, the laws. And basically, you had to get police involved to try and to kind of take away his license. They had to be called and said, we don't think he's safe to drive. And we thought that, this is the best thing because he's definitely not safe to drive. Best for him and best for us because he was living on his own. But when Adult Protective Services went out there, his house was perfect, immaculate, definitely cleaner than mine. I mean, it was great. Well, we got him kind of involved into the system, and they put him in a nursing home, and he got COVID and died 2 weeks later.
And oh my goodness!
And this guy had, dementia for sure, and definitely not safe to drive, and living on his own with nobody in the world, but generally been doing great at home. And so on the medical side of things, doctors always second guess themselves. What should we have done different? How could this have been prevented? And sometimes there's medical errors. And this is a good example where I don't think we necessarily did anything wrong. You couldn't predict that, but it just shows how complicated care for people with dementia is. And it did not work out well in this patient's case. And so I feel sad about that for sure, but I'm not sure what I would have done different. And I think it's a telling story because it highlights some of the challenges that, like your story as well, family members are trying to deal with apart from the medical side of things, just the daily life. And then we're also going to talk about some of the ethical stuff with feeding tubes and whatnot at the end of life.
Yes.
There's a lot to
Yeah.
cover here. It's a complex issue.
Well, this episode was actually suggested by our friends at the National Catholic Bioethics Center. They said some of the most challenging ethics consults they get revolve around dementia. So to start the second half of the interview with Leah, and she's been prepped with the questions, we have some questions which are from our friends there, and it's a clinical scenario. And I think that's going to be exciting to see how Leah answers that.
Yeah, I think it'll be great because these are things that I get to talk to people about. I know it's the biggest things people are asking about when they have a loved one nearing the end of their life with dementia. And hopefully we can be a resource and point people in the right direction.
Yesterday I had another sweet dementia patient. Most patients seem to be sweet when they get dementia. Some turn the other way, even though they were always sweet before. But this one, God bless her soul, every 20 or 30 seconds now, what are you doing to me? Oh, cancer. I thought it might be cancer. And, oh, my niece came up from, X city. She always comes up to take care of me. Yep. Isn't that great of her? 30 seconds later, did you know my niece came up all the way hour and a half to take care of me today? Wow, that's wonderful. And to try to treat each time like it's the first time you're hearing it is a challenge. I don't know. People who take care of dementia patients, I think, are heroic.
Yeah, I think that is a unique gift. And if people don't have it, they get it real quick because, you have to learn patience to be able to care for these folks with love. I remember another patient of mine, as her dementia got worse, her voice just got softer and softer. And so it was mostly whispers at the end of it, everything. I'm like, I can't
Yes.
hear what you're saying at all.
Oh, put your
But
ear up next to her.
such a pleasant person. So by far and away, most pleasant people are the memories I have. But like you said, sometimes it affects the personality in negative ways too. And how do you cope with that as a family member? So
Yes.
lots to cover.
Well, the only data we're going to give you in the first segment is from age 65 to 74, about 3% of Americans are diagnosed with dementia. The next decade, from 75 to 84, there's 17%, and just about a third of those 85 and over. But our medical trivia question of the day, category brain power. Yes, the brain is made of neurons. That's the fancy word for nerve cells. How many nerve cells are in the average adult brain? Multiple choice. A, 10 million, B, 100 million, C, 1 billion with a B as in boy, D, 10 billion, or E, 100 billion. And the bonus, how many unique connections between two different nerve cells are there in the brain? We call these synapses. For these answers, you're going to have to wait till the end of the show, but after the break here, we'll be back with Dr. Leah Acosta on dementia here on Dr. Doctor. Welcome back to Dr. Doctor, where we have Dr. Leah Acosta, who is an expert in neurodegenerative diseases with us. She's at Vanderbilt University Medical Center, but she graduated with high honors from George Washington University and completed studies in psychology, philosophy, and physiology, the 3 Ps, I guess, at Oxford University in the United Kingdom. She did her doctor and neurology residency at the University of Virginia in Charlottesville, and then a fellowship in cognitive and behavioral neurology at the University of Florida. She focused on creativity, which is a fascinating thing, maybe another show on that. Her interest in this topic stems in part from her own hobbies of creative writing, drawing, and calligraphy. She joined Vanderbilt University Med School in 2013. She got a master's in public health at Vanderbilt, the eternal student. She's co-editor of the humanities section of the journal Neurology. She conducts clinical research in Alzheimer's disease and other dementias. She also teaches students and enjoys teaching students and residents very much at Vanderbilt University, and she's an active member of the Nashville Guild of the Catholic Medical Association. She's also has some wonderful children, and we're happy to have Leah Acosta with us. Welcome to Dr. Doctor.
Thank you so much for having me.
So, Leah, how did you get interested in pursuing research in the area of dementia?
Yeah, it's an interesting lifelong story, actually. My mom actually does stress and pain therapy. And when I decided I was going to be a doctor when I was about 6, I thought I was going to be a
Why did you wait
psychiatrist.
so long?
I know. And so all throughout undergraduate, again, majoring in psychology and then going on to graduate studies, psychology was definitely at the forefront. I just fell in love with some books that I read about written by Oliver Sacks when I was an
Hmm.
undergraduate. I just fell in love with the abnormal psychology. Some of the pathology is really interesting to me. And so I thought I was going to do psychiatry up through medical school. And then I just fell in love with neurology. And what I loved about neurology was I loved being able to physically examine somebody, to do a thorough neurological exam and be able to
Mm,
localize where the lesion was, whether it was in the
yes.
peripheral nervous system or in the central nervous system. And then I just, again, always having loved the brain, I really loved, specifically within behavioral neurology, how if you did a careful interview, you asked the right kind of cognitive questions, you did a cognitive screening exam, in conjunction with the neurological exam, you could localize exactly what parts of the brain were not working properly when you examine a patient with some sort of cognitive impairment or dementia. And so that's why I decided to do fellowship in this area, because I just thought it was intellectually fascinating. I also love the patient population, just because older patients have the best stories. And so it's always fun talking to them about, their kids or their grandkids or the work that they did or the things that they're doing in their retirement. Another personal interest of mine with this was my maternal grandfather actually had dementia. So he had a series of strokes and had what's called a vascular dementia, because his cognitive function declined with each stroke that he had. So a little bit of a personal connection. He started having that about when I was in grad school, starting medical school. And so I didn't really see it personally because he was in the Philippines at that time, but just hearing the stories about how he had changed was something that I think subconsciously probably influenced my decision to a certain extent.
Well, Leah, you brought up the term vascular dementia.
Hmm.
What, maybe even more basic, what is dementia and how
Sure.
is that different than Alzheimer's disease, or is that just one type of dementia?
Yeah,
What are the
that's
terms we should think of?
Yeah, that's a very common question that I get from patients. So I'm glad that you asked that. So dementia is more what we call an umbrella term that means that a patient is having problems with his or her memory, thinking, language, some aspect of their cognitive function, to the point where they have a decline in their usual daily tasks. So if they are still working, they're not able to work the same way, or they're not able to work at all, or even just with hobbies, somebody who plays their weekly bridge game, if, they have a decline in their card playing skills, and that can be a sign of dementia. So basically, it's any medical reason why somebody is having a decline in cognitive function where it impairs their daily tasks. So Alzheimer's disease is the most common form of dementia, for example. And so the analogy I like to give to patients is that if you think about the word fruit, you know what fruits are. You got apples and oranges and bananas and things like that. So dementia equals fruit. And so when you have the different types of dementia, you got your different types of fruits. You got your apples and your oranges and bananas and your kiwis and your mangoes and things like that. And so I like to help distinguish that for patients, because not all Alzheimer's disease is dementia, not all Alzheimer's disease is dementia. And that's, I think, where people get most confused about that terminology.
Oh, so you
So
can have Alzheimer's disease without having dementia?
Yes. So the general
Oh.
categories that you can get are basically if somebody has normal cognition, somebody can have a mild cognitive impairment stage of their cognitive impairment where they have some decline in their cognitive function, again, memory, thinking, language, some
Mhm.
aspect of their cognitive function, but it's not affecting their activities of daily living to the point where they've had to stop doing stuff. And then the next stage, when they start having a decline in those activities of daily living, that's when it's
Okay.
classified as having a dementia. So there's a little bit of a gradation. This is terminology that's really evolved over the last 1 to 2 decades. And so
Mhm.
we're still, trying to refine the definition of some of these things, but there is a way where somebody can have an earlier stage of cognitive impairment that's not quite full-blown dementia, so to speak, but it can be in a more of a mild cognitive impairment stage.
So dementia affects people's personality. We see their personalities changing. First, how does it do it? And can you predict how somebody's personality will change with dementia?
Mhm. That's something that I see to a varying extent, and it really depends on the individual. And that really ultimately depends also on the type of dementia. So, for example, there are certain types of dementia that, by their definition, change somebody's personality. So, for example, there's a type of dementia called frontotemporal lobar degeneration. Some people may have also heard that referred to as frontotemporal dementia. And one of the main types of frontotemporal lobar degeneration is what we call behavioral variant frontotemporal lobar degeneration, or FTD or FTLD. Sorry, it's a
Oh,
bit of a mouthful, all
yes,
these terms.
yes.
And
I can see why everybody lumps them together.
yes, and also just I mean, medicine is rife with alphabet soup, anyways. But FTD for short.
Yes.
And so the definition of FTD is patients have a marked change in their personality. So all of a sudden they were always really mild mannered and kind of meek, and all of a sudden they're just
Mhm.
brash and out there, or they're swearing
Yes,
left and right.
yes,
They're going out at all
yes.
hours. You can see those kinds of personality changes, and that is not uncommon in that specific type of dementia. And in other types of dementia, I see almost more of just an enhancement of who that person naturally is. So if they're just gentle and sweet, they just get more gentle and sweet. If they're maybe a little difficult to deal with at baseline, that can also get
They're
enhanced,
more difficult.
unfortunately. More difficult,
Yes.
more stubborn, or more opinionated, and things like that. And so it really just depends on the type of dementia, and it's really hard to predict how some people may change. Again, it depends on an accurate diagnosis of the type of dementia, and just some of those changes that you might see.
Okay. Well, one of the things that people ask about is getting a diagnosis,
Mhm.
specifically of like Alzheimer's disease. How do you diagnose people with Alzheimer's disease?
Sure. So I'm going to take that question in two parts, just because, as we talked about, the diagnosis of dementia is a broader term compared to specifically diagnosis of Alzheimer's disease. And so, with most of the dementias, and mostly I deal with what are termed the neurodegenerative dementia. So there's a neurological etiology for these symptoms, a neurological reason why these patients are having these symptoms. Most of them are what we call clinical diagnoses. And so you basically check the box for certain symptoms to meet diagnostic criteria for those different types of dementias. And so, as part of any good general dementia workup, there has to be an examination by specialists in the area. And I think a lot of primary care doctors, geriatricians, psychiatrists, neurologists are usually comfortable making this kind of a diagnosis. You can subspecialize, as I did within this field, where I've done subspecialty training by doing a fellowship in this specific area. But you don't necessarily have to see a specialist in the area, even though it can be helpful, especially if it's more of an unusual presentation. So, as part of that workup, you usually talk to the doctor. Um, Often patients with dementia don't realize they have dementia. That's one of the common symptoms that we see depending on the type of dementia. And so they're usually accompanied by a caregiver or loved one, typically a spouse or child or somebody like that, who can help support the symptoms as to what the patient has been exhibiting. And then there's, of course, usually an exam that goes with it. And then most workup includes getting blood work. So, blood work for treatable cause of memory problems, whether somebody's got an endocrinological problem like thyroid disease or a vitamin deficiency, because some of those things can manifest as having a dementia. Usually, getting some sort of a brain imaging, like a computerized tomography or CAT scan, CT scan of the head, or even getting magnetic resonance imaging or an MRI of the brain can be helpful, just to make sure there's not something else going on, like a tumor, or somebody actually had a stroke and nobody really realized it, or something like that. So that's generally the basic workup for having a dementia. As far as the specific
So,
diagnosis for oh, sorry, was that a question, or
no, so
you keep
if
going?
a
Okay.
listener thinks that mom or dad, grandma or grandpa has dementia, what's the first appointment they should make?
I think definitely starting with the primary care doctor, just because usually that is the physician who knows the patient the best. And so just to make sure there's nothing, that they've been keeping an eye on
Great.
something, whether the sugars have been really high, or again, maybe that thyroid has been hard to control, just making sure that there's nothing else going on that would potentially be contributing to those symptoms. So definitely starting with the PCP. And if the
Great.
PCP thinks that a referral is warranted, then they would make that referral, again, whether it's to psychiatrists, neurologists, or somebody else
So,
specific to work that
so
out.
now we know we have fruit in the shopping cart. How do we figure out which fruit we have?
Exactly. So it really, again, it's part of that workup. So there are characteristic changes that you can see, for example, with Alzheimer's disease on brain imaging, or Alzheimer's disease versus frontotemporal dementia, FTD, that I referenced earlier. That typically has a different appearance on the brain. Specific to Alzheimer's disease, the question that you asked me earlier, Andrew. Usually the clinical diagnostic criteria and doing the brain imaging, the blood work to rule out treatable causes of dementia is sufficient. Sometimes, depending on what the presentation is, if there's still some diagnostic uncertainty, there are additional tests that could be done. So, for example, somebody could get a spinal tap or a lumbar puncture to look at spinal fluid to check for changes related to Alzheimer's disease. There's also some imaging that can be done. So, fluorodeoxyglucose positron emission tomography or FDG PET scan can be done, which basically looks at sugar metabolism in the brain, which can indicate an underlying dementia. Some academic medical centers also have access to other types of PET imaging modalities like amyloid PET and tau PET that can look
Hmm.
at in vivo imaging, while somebody is still alive to see presence of that pathology in the brain. That's usually pretty
So, and by the way,
specialized. Not
those are the
everybody gets it.
proteins that are deposited in the brain in high numbers that cause some of the symptoms of Alzheimer, that tau
Correct.
and
Specific to
the
Alzheimer's
amyloid.
disease, the tau and the amyloid, yes.
Yes. So,
Okay.
that's great information. What people really want to know is, when is my forgetfulness normal and when is it a problem?
Yes. So I think one common misconception and understanding we're trying to address is that dementia is inevitable as we get older. Because a lot of times people just brush things off. Oh, grandma, that's just, old age, and it's normal if she doesn't know how to, cook her famous Christmas cookies every year. She doesn't remember the recipe anymore, that kind of a thing. And so, because I think we all know people up in their 70s, 80s, 90s, 100s who don't have any degree of cognitive impairment. So we're really trying to
Right.
emphasize to people that maintaining one's cognition is to be expected and hoped for as we get older. I think some aspects of cognition that change as we get older, for example, coming up with words for things or coming up with names for people, because you think about how many people named, Tom or Andrew you've met over the course of your life. It's probably a lot of people,
Names are the
especially
worst.
when you're getting up there, because you've met so many people by the same name. So it's not that hard. I mean, I remember even my fellowship mentor who's been practicing medicine for over 40 years, like he personally would reassure patients. He's like, I forget names of people sometimes too, and that's okay. So I think, it's normal for there to be a little bit of a delay sometimes, or even forgetting, just because when you've got a lot of competing information there, it's normal to forget that. And I also tell patients sometimes, they get frustrated with themselves because it takes longer to come up with information that, they used to know in a snap. And I tell them, let's be honest, can you run a mile as fast as you did when you were 18 years old? And most people say no. And I tell them, well,
Well
it's kind
said.
of not fair for us to expect the brain to function the same way as we did decades ago, because the brain can also slow down too to a certain extent. So even if it takes you a little bit longer to get there, as long as you get there, it's probably not something to be worried about. So there are some aspects, again, of that slowing, or when there's a lot of competing information, that is pretty natural. I think when I would start to get worried about it is if people start to notice persistent symptoms, or it does start to affect those daily activities. So again, grandma, okay, grandma forgets my name, but then they start mixing up names of kids and grandkids, or in some cases great grandchildren. They're thinking neighbors are their children, or that kind of a change. Or if they're, again, needing a lot more help doing stuff, or they've had to stop doing. So like I give the example of grandma and her Christmas cookies, you know what I mean? So it's like, okay, maybe one year she forgot to put the salt in, and then maybe the next year she forgot a couple of ingredients, and then maybe the next year she didn't remember the recipe at all. It's that kind of a change where I would start to get more worried when somebody is either needing a lot more assistance doing stuff that they used to be able to do without any problems, or they simply can't do it anymore.
Leah, you had made a comment earlier that I caught on to, is that frequently people with dementia don't realize that it's a problem.
Yes. Hmm.
Is it safe to say the other way around? People who are worried about their memory so much, most of the time it's not dementia. I mean, I feel like I've seen a correlation, but you're the
Yeah.
Good
specialist.
question.
It's hard to make a blanket statement, but generally speaking, in a lot of dementias, not all of them, especially as the disease advances, patients don't realize that they have a memory problem. Now, some studies have specifically looked at this, and they found that maybe in earlier stages of the diseases, maybe some patients do have a little bit more insight into that awareness. So, for example, just using Alzheimer's disease, if we look at a patient who has a mild cognitive impairment, secondary to Alzheimer's disease, they might realize they're having problems with their memory, and they might even come to you and say, yeah, I've got problems with my memory. Versus when they're more advanced in the disease process, they might be like, no, my memory's fine. My brain's working great. So it's not something that is always seen in patients who have cognitive impairment. I do see also a large number of patients who are inordinately worried about their health. And in some of those cases, it's because they just have a heightened awareness because, mom was diagnosed with dementia. Or sometimes, for example, in people who are really depressed, they tend to glom onto the negative, and so they start to get worried that they're forgetting things because they remember the one time they forgot something and they don't remember the 99 other times that they remembered it. you know and so it is a little bit of an inverse correlation from what you've seen, Andrew, because I've also seen that in my patients as well, where the ones that tend to be the most worried are often not impaired, or maybe are more in early stages of the disease, versus the people that have the anosognosia, where the medical term for that, they don't know that they're impaired, tend to be more with advanced disease.
Leah, before we get to the second half of the interview after the break, which is going to mainly cover a lot of ethical things and some Catholic specific questions, I think main question I have, and maybe a lot of listeners have, is, okay, I have a strong family history of dementia on one side of my family. And I've seen the study of the religious sisters who let their brains be autopsied after death,
Sure.
and found that some of them had shrunken brains and signs of Alzheimer's that was very advanced, yet clinically they were normal. So is there something we can do to prevent the effects? And if so, at what age should we start doing them, and what should we start doing?
Should have started it yesterday. No, I'm kidding. So I think it's never too early to start, because a lot of things that we know are associated with a higher risk of developing dementia are things like vascular risk factors, so high blood pressure, high cholesterol, diabetes, all those kinds of things. So making sure any medical problem is appropriately diagnosed and treated. There's also been a lot of research showing the benefits of cognitive exercise, physical exercise, a healthy diet, so specifically the Mediterranean diet, or there's a newer version of that specific to patients who have high blood pressure called the MIND diet. We're focusing on things like fresh fruits and vegetables, lean meats, healthy fats, avoiding things like butter and deep fried things and a lot of red meat. I live in the South because I'm in Nashville, so a lot of deep fried things here in the South. So I joke with patients about, trying to minimize that kind of food in the diet, because the studies have shown that people who are cognitively healthier, physically active, addressing their medical problems, eating a healthier diet, they can lower their risk of having developing dementia. It's not 100%, but those are all things that you can do just to be healthier in general and also decrease one's risk of developing dementia.
What is cognitive exercise, and what's the effect of socializing?
Yes. So yeah, that's great. I'm glad you brought that up, because I should have mentioned that specifically as well. So two things as far as the cognitive exercise, whatever you can do to engage the brain. So for a lot of patients, like sitting back and watching hours and hours of television, not the most stimulating activity, but things like playing card games, or, playing with your grandkids, or reading, or, any kind of activity like that that helps engage the brain in a different way. There's also been studies about patients who take up new hobbies, like they try to learn a new language or start doing art, or, picking up a new hobby can all be ways of exercising the brain. Socializing is also really important, because that's a good way of exercising the brain, because, if you're talking with different people, you're engaging in different conversations, you might not have thought about that particular topic, but you meet somebody new and that comes up. So that helps stimulate those neural networks and maybe, strengthen some of those pathways. And so that socialization is not only good for just cognitive health, but also for emotional health, because a lot of times if people are isolated, which we've seen a lot of in the pandemic, unfortunately,
Yes.
it's important for people to maintain those emotional connections, because that overall helps one's health, and of course can also help one's cognitive health.
So what's good for the heart is good for the brain, is part of what you're saying.
Yes, that's definitely a
Excellent.
common adage.
We'll be back with more on dementia with Leah Acosta here after the break on Dr. Doctor.
And we are back with Dr. Doctor, and we're talking about dementia today with Dr. Leah, super subspecialist in dementia. Tom listed everything. I can't remember them all. I hope it's not dementia for me. We're into the second half of the show where we're going through case studies, and these are from our friends at the NCBC. So, Leah, I'll start out with this first one. These are a little bit long, but this is an 85-year-old woman with advanced dementia. she's lost the ability or maybe forgotten how to swallow. The nursing home hospice provider has a policy that when patients can't feed themselves or give drink to themselves, they don't offer any food or fluids. And specifically, they don't give them a feeding tube or IV fluids. The family members are worried because their loved one has not had anything to eat or drink for 3 days. And they're worried that that's contributing to their mother's death. This is something that happens a lot. How should we think about this? What should we do, especially as Catholics?
Sure. So that's a scenario that I see every once in a while in patients with advanced dementia, because sometimes as the dementia advances, certain bodily functions shut down. So, for example, people just forget to eat, or they forget to swallow, or there's some aspect of their bodily function that is impaired, and so it's something that I typically see in a more advanced dementia, and it can be really difficult for family members to deal with it because as we discussed earlier, sometimes, especially in dementia, um, patients aren't aware that something's going on, and so they they're usually okay. It's more affecting the patient's family members.
It's
So it's
something that I think a
Mhm.
lot of people kind of feel pressure to be the one to decide, especially if there's a policy that says this is not an option. Then
Sure.
I think a lot of patients feel like, holy cow, this is on me to figure this out.
Yeah.
So I guess to clarify, maybe medically speaking, how should we approach the question of providing nutrition and hydration for advanced dementia patients
Sure.
who can't swallow anymore?
Sure. So, medically speaking, of course, we want to factor in what the patient's and family's wishes are regarding an invasive procedure. Just to bear in mind, for example, there are different types of feeding tubes. So, there are temporary feeding tubes, for example, a nasogastric tube that go from the nose to the stomach, and there are more permanent feeding tubes that can be put into the stomach. And even those aren't necessarily permanent. Sometimes people get them removed at a later stage or they don't use it. So it's not necessarily an all or nothing thing. So I think it's really important to always remember, first and foremost, especially as physicians and especially as Catholic physicians, the dignity of each person and these basic needs and, rights that we have to nutrition and hydration. And I think it's important that all that is always offered to the patient. Now, sometimes patients have different physical changes that makes them unable to swallow, um, or even sometimes bodily processes change and nutritional needs change, and people don't eat or drink as much as before they had dementia. And especially as dementia advances, those kinds of nutritional needs can also change. So I think it's always important to offer, especially through hand feeding, food, water, as best we can, but sometimes we have to acknowledge the fact that some patients can't process food and drink the same way that they used to. They may not have that same drive to seek that kind of, nutrition and hydration. And just, as those metabolic needs change, sometimes it's not feasible to have that happen.
So, how can we tell when it's the time that, if it's within days of death, withholding food and water is not immoral?
Mhm.
How can we tell when that might be the case?
Sure. And I think it's always important to offer, as we talked about before, there's been a lot of research about hand feeding and how sometimes that's as good as, putting in a feeding tube, just taking the time and being patient. And if somebody basically isn't making any moves to, chew or swallow or to seek out food, it's not like you're deliberately withholding nutrition and hydration from them. You're offering it and you're trying to, put a few ice chips or something like that. And as long
Sure.
as you're attempting to offer those basic needs of food and water, if the body isn't ready to process it, then I think you've done your best and you've done your duty.
So, in other words, if you think they might live for weeks or months with
Hmm.
food, can a feeding tube be ethically withheld if their cognitive decline, their thinking ability is no longer there to remember how to swallow or how to
Hmm.
eat?
Yeah. So, I mean, I think it's important to differentiate as well if somebody has a treatable cause and if somebody has a permanent cause that's affecting their
Sure.
hydration. So, the most memorable example that I have from my experience is I have a patient who was diagnosed with progressive supranuclear palsy, which is a type of dementia.
Yes.
And he was
Yes.
having a lot of difficulty articulating words and swallowing. And he had an acute worsening of his symptoms, was seen at a local hospital, and they were basically just writing this off as his PSP. And knowing the
Yes.
patient and his wife really well, I was worried that he had had a stroke. And so I
Ah,
pushed the outside hospital to get a brain MRI to evaluate for stroke, and lo and behold, he had
Right.
a stroke. Because I had had conversations with the wife and with the patient about feeding tube, and it's not something he necessarily wanted, over the course of his PSP. But because he had had a stroke, I knew there was a chance he could improve and regain some of the function that he had lost, because most strokes tend to get better. And so when we had the diagnosis, he did get a feeding tube placed, and he lived for another 2 years after that incident, which the wife
Very
was
good.
grateful for that extra time with him, because if we had just written him off as this, oh, it's just his dementia, can't swallow anymore, she would have had 2 years fewer with him. So being able
Okay,
to
Leah,
distinguish.
here's the second part of the question the NCBC really wants
Yep.
your advice on. So, assuming either that no nutrition and hydration are offered because they've turned it down, or they're turning it down when hand feeding is offered, how
Sure.
can family members be assured with moral certainty that their loved one will die as a result of their underlying dementia and not due to dehydration or starvation? That's a common question the NCBC
Yeah.
gets.
And I think it's important, obviously, when one is dealing with that situation in the moment, just to look at the history of the patient. Because if you see that dementia has been advancing to the point where people aren't swallowing, where people aren't really taking in that food and drink, this is a natural progression of that dementia where the body's just ready to go. Because it's not just those functions. It's, the heart is changing and the kidneys are changing and things like that. And so it's not
Ah,
uncommon for that aspect of the bodily function, swallowing, digestion, to also get impaired. And so all those things can be seen with advanced dementia, where this is a part of the disease process.
that makes sense. That's exactly what I saw in my dad 3 months
Mm-hmm.
ago when he died with
Sorry
Alzheimer's.
about that.
His
Yeah.
kidneys shut down.
Mm-hmm.
His sodium was like 176, which I thought
Yeah.
was incompatible with life. And
Yeah.
he was eating less and less. So I can see now where it's a whole picture. It's not just the brain, the whole body can be involved.
Absolutely. Absolutely.
And at what point, one of the follow-up questions from the NCBC is, when is it feasible for clinicians to monitor for signs of dehydration or starvation
Mm-hmm.
as a way of telling if they should offer supplemental nutrition?
Sure. It's important, again, to look at the patient in context of their disease process. Is this something acute? Is this something chronic? What is the underlying diagnosis? Because certainly there are things you can do to monitor, for example, kidney function, like you mentioned in your dad, Tom,
Yes.
like, what their creatinine, what are their electrolytes like?
Right.
And you can tell if somebody's dehydrated from that, or you can tell if somebody is, not taking a lot by mouth. Is there muscle breakdown? Measuring certain labs with that. So there are ways to monitor people's nutritional levels or hydration levels based on either tests or just their physical appearance, and just really making sure that you're careful to distinguish, is this something that's part of a chronic process? Is this something acute? Is this something reversible or not? Just keeping that in mind.
So it maybe to summarize a little bit, it kind of highlights the challenge of these scenarios is that it depends on the patient. And
It's all
for
very
one
patient dependent,
patient, it
yes.
might be a reasonable thing, and for another patient, it might be clearly unreasonable.
hmm So, just to go back to the scenario I talked about with a patient with PSP, if we had ruled out
Yes.
everything, he did not have a stroke, and we knew that he had a worsening of his swallowing because of his PSP, would we necessarily have pursued a feeding tube? Maybe not, because he had said before that if it's related to his disease process, he didn't want anything invasive. And especially, you have to also factor in that those kinds of procedures, as commonplace as they are, it's never minor surgery when it's your loved one who's going through it. So there's risk of infection, undergoing the anesthesia. Sometimes, the cure can be worse than the actual disease, because if you've got a really agitated patient who's always trying to pull out that feeding tube, ultimately, that's probably not the best decision to make for that patient's long-term benefit.
Well, let's move along to treatment for dementia. Is there any treatment that makes a difference? What are we to think of the various medications out there, Leah?
Mhm. So, unfortunately, I wish there were more medications than are currently approved for different types of dementia. I think there is certainly some benefit, which is why these medications are approved to begin with. So, again, taking the most common cause of dementia as far as Alzheimer's disease, studies have shown that patients who are on the medications, the cholinesterase inhibitors or the NMDA receptor antagonists, they do better in the long term. So, their cognitive function stays more stable. It delays nursing home placement. They live longer. Because a common thing that I hear patients is that, well, I started taking it, or more specifically, family members, and I don't notice any difference. And I tell them that's kind of the point. Because when I tell them that patients are typically slowly getting worse over time, the medications don't stop the disease, but it does help plateau them a little bit. They're still going to continue to get worse, but it just helps provide more of that stability. And so even though they say that's not doing anything, I know that it is, because often in patients who stop it for whatever reason, I see them get worse a lot more quickly. So to help them maintain as much as
Ah,
possible, I encourage them to continue taking whatever medications are prescribed for their dementia.
Sometimes I've had a patient recently who started taking them, and he said he was doing way better. I said, I don't think they're supposed to work like that.
I do.
I think that's called the placebo effect.
Debbie Downer, Andrew.
I do have patients who tell me that they think they're doing better, or, more specifically, family members who say that so and so is doing better. And I mean, if that happens, great. But as we were just reviewing, it's not something that I expect, but I'll take it if I can get it.
So for people
So
we anticipate they're going to have worsening, we've already diagnosed them with dementia, you'd recommend for the most part people should take the standard approved drugs that are available.
Sure. I mean, we always have to weigh the risk benefit ratio in any one particular patient. And no medication is without side effects. So there are certain things where if you have particular conditions and it's not indicated, this would be contraindicated in this particular population. So, for example, with some of the cholinesterase inhibitors in particular, can be dangerous in people who have certain heart arrhythmias. And so, maybe you wouldn't want to start that in somebody who might have a risk of a heart side effect. But generally speaking, I do recommend to most of my patients to go ahead and start on a memory medication.
Leah, a lot of people, when they meet someone with dementia, aren't sure how to communicate with them. I've learned my own things over decades in medicine, but was never really taught. What advice would you give to people for communicating with somebody with dementia?
Yeah, so I mean, I would talk with them just like anybody else, because they're still human beings, they're still children of God, and so they deserve equal dignity and respect when we're interacting with them. I think a lot of times people end up infantilizing patients with dementia, and they talk down to them, or
Yes.
baby talk or things like that. And patients know if you're treating them with respect or not. I mean, and a well-meaning person could potentially approach a patient with dementia
Yes.
in that vein, but they're still adults. They've still lived these really long, full lives. And so just talking to them like you would talk to anybody else. Certain patients, you might need to remind them more, or you might need to simplify the language more based on their level of cognitive impairment. But I think a smile goes a long way. Just like a nice, gentle hand on theirs or something like that to make that connection with them. But just making sure that you're not dumbing things down too much when interacting with them.
Is it sometimes important to talk about long-term memories versus recent events in their lives?
Sure. I mean, a lot of patients with dementia, those long-term memories stay there for a really long time. And so they love to wax poetic about their childhood or their experience as a young adult or when their kids were little and things like that. And it's kind of a safer space for them to spend time
Mhm.
because short-term memories are so impaired. So they may not remember, that their kids visited last weekend, but they'll remember that summer vacation that they went on when it was their first time going to that amusement park, and so they really enjoy talking about those long-term memories.
Leah, can we talk a little bit about the caregivers as well? I know dementia can cause a lot of suffering,
Mhm.
not only for the patients, but also for the family and the loved ones, who care for them. I think about you caring for these people, even in the clinic. You must be a ninja at the virtue of patience. Um, how how can we get better at this if we're caring for a loved one? Maybe a
Sure.
word of encouragement or advice in trying to carry on like this.
Yeah. And it can be frustrating because, if you've told somebody the same thing 20 times or they keep doing things that they're not supposed to be doing, I can certainly see the frustration in patients because, if I'm only spending 30 minutes, 60 minutes with a patient and I'm seeing elements of that, I just can't imagine what it's like for family members who have to live with that day in and day out. I think one of the first things I always encourage patients is that the patient is still the patient. I know that sounds kind of silly to say, but especially if the personality has changed or they're doing things they normally wouldn't do, it almost feels like, well, that's not my spouse or that's not my dad. It is that same person. It's just the instrument of expressing those memories or that personality is damaged because of the dementia. So just remembering that it's still your loved one. And then just reminding yourself it's the disease, not the patient, when you have to say things 20 different times, and the patient's not going to remember it. And just recognizing that dignity. It's kind of like I've got small children at home that you may have seen earlier in the broadcast, where, how many times, like, wash your hands? Did you remember to say please? That kind of a thing. You do those things because you're trying to reinforce that with your child, and you love your child. And it's the same thing if you've got a loved one with dementia. You have to reinforce what's important, and you just dig deep to find those reserves of patience to treat your loved one with dignity.
When you have people who are in repetitive, a common thing would be like a repetitive thought process.
Mm-hmm.
Sometimes you see folks, maybe even out of frustration, challenging that. That's not reality. That's not accurate. You already
Mm-hmm.
asked me that 20 times.
Sure.
Is there fruit in trying to redirect them, or is it better to kind of play along, so to speak? I mean, some of these things are hallucinations or paranoia,
Yeah.
even.
I think a couple of things that you mentioned are totally reasonable avenues to take in terms of redirecting. Oh, that's interesting. Okay, what do you want for dinner? Or just trying to distract them, basically distracting them. I think it's important not to engage too much. I think certainly determining if the person feels unsafe or threatened to try to address that, because maybe there is something else deeper that's going on, or something that may need to be addressed with a medication. If you think you see somebody like hiding in your closet with a knife or something like that, then certainly you might need to take some steps to address that with medication, or moving whatever it is that the person might be misinterpreting. But I think we all love being right. And I've seen patients and family members just go at it because, well, he said this, but that's not right, and blah blah blah. And it's fruitless to engage in that level of discourse, because the person with memory problems is not going to remember that. And so distraction, redirection, all those things are reasonable, because you just don't want to waste breath engaging when you know that nobody's going to remember what the truth is.
I've read that sometimes a diagnosis of Alzheimer's disease can be made 20 years before dementia occurs. Is there a reason to get a test done to see if we might be that way, or should we all be doing the right things early? Or would you start one of those drugs earlier if you could diagnose it 20 years ahead of symptoms?
Sure. I mean, as we talked earlier, I think anything you do to stay as healthy as you can physically is going to help your cognitive function in the long run. The question of what we call preclinical Alzheimer's disease is primarily still a research related question. It's not one that
Sure.
we're making recommendations to people, for example, who have a family history, who are concerned about their memory. Because really, one of the core aspects of the definition at this point, in terms of making the diagnosis, is having those documented objective cognitive changes. And
Mm.
so, you can certainly be worried because mom had Alzheimer's disease, but it's not something where it's not like there's one test that you can do to tell you whether or not you're going to develop Alzheimer's disease. It's just trying to stay as healthy as you can, and, keeping an eye out for that stuff. And if it comes to a point where you are worried that you're having those changes, to go ahead and get evaluated.
Man, that's
So,
great.
yep, as we wrap it up here, what
Yeah.
final advice do you have for our listeners on what they should do or where they should get more information?
Sure. I mean, I definitely want to encourage everybody to stay as healthy as they can, so they don't have to see me in clinic. So that cognitive, physical exercise, healthy diet, all that stuff, to stay as healthy as you can. And certainly, if there's any questions about any degree of cognitive impairment, to first talk with your primary care doctor to get an assessment, and if necessary, get a referral to a specialist. And I'm happy to see you if I need to.
Thank you, Leah. It's been a pleasure having you
Thank
here
you
on
very
Dr.
much.
Doctor. We
Thank
hope to
so
have
much
you
for
back
having
again.
me.
And we are back with Dr. Doctor. After a great interview, we've got the answer to the trivia question everybody's been waiting for about brain power.
So, how many neurons on average does the adult brain have? And the answers were in multiples of 10, starting with 10 million up to 100 billion. And the answer is the highest number, 100 billion. B as in boy, billion. That's a whole lot of cells. But
Usually, I don't
even
think
more.
about numbers this big except for like congressional deficits and stuff like that. But brain neurons, too, they're way up there.
Well, what's even more astounding is the number of unique connections between the neurons in the brain. So how many of those are there? There's 100 trillion. T as in tsunami with the silent T. No, T, T as in Tom. So that means
How in the world
each
they count
neuron,
all those?
I don't know, but each neuron on average would have a connection to 1,000 other neurons. That's amazing.
Jesus. Yeah, sounds like something that happened by random chance with evolution, right?
There you go.
No?
Ba-doom, boom.
Sarcasm.
That's right. So, top 3 takeaways, Andrew, from Leah.
Yeah, so many things we could talk about. I'd say I always think of homework. Number one, Prevention. Prevention is an ounce of prevention is worth a pound of cure, I've heard. And the
Thank
nice
you,
thing is
Ben.
to try to try and prevent dementia. You're got to do the same stuff to prevent all the other problems. So try and live healthy, eat healthier, maintain a healthy weight, exercise, have friends, get out, go to church, and be balanced. Don't be too crazy in one way or the other. So prevention is number one. Number two, I would say, in regard to all the ethical stuff regarding feeding tubes, it's a question that gets talked about a lot. Every patient is different. You got to find people who know a little bit about this stuff and people who you trust. Our friends at the NCBC do ethics consults. I'd refer people to them if you don't have somebody local that you already have a relationship with.
And I had an aha moment when she said the whole body is just getting ready to run down and die with Alzheimer's. And that really struck me, like I said, with my dad. So it kind of made it more rational to say that there might be times when you don't have to put down the feeding tube. That
That's right.
surprised me.
I think some people feel like you got to hurry up and get one in before they die, and that's definitely not the case. And so it's very patient individually has to be decided, and it has to be for the good of the patient. And there's sometimes when it's not.
Yes.
So
And
that's
number
number two.
3,
Last but not least was a question I was interested in: the drugs.
yes.
Some people love them, some people hate them. You can't tell a huge difference most of the time, but from the super specialist, Dr. Leah, she says that they are a good idea to do for early dementia to stop and slow the progression. So I'd encourage y'all to do them.
Amen. And we thank you for listening to us and some of you watching us for another episode of Dr. Doctor. You can find this and all old episodes on our website, drdoctor.org. Just click on episode archive at the top where you can search over 275 episodes by topic or guest.
I was keeping track. I like that. If you haven't listened recently, we now have a video version of our podcast. Click on the YouTube link near the top of our homepage at drdoctor.org. And if you have a question or a great idea for an episode, only good ideas, please, click where it says submit a question. Click there. Give us the good ideas. We'll take them.
This is Dr. Tom McGovern.
And Dr. Andrew Mullally. And we're signing off until your next dose of Dr. Doctor.